Hi, everybody. Good morning. And I should say Merry Christmas, Happy New Year's. It's going to be another new year, maybe not quite the better year. But welcome to Beyond Telehealth. And I'm Lisa Finkelstein. I'm going to be your host for today. And we have two wonderful young physicians, young innovators who are going to help lead us into a discussion about hospital at home. So let's jump right in and let's have you guys introduce yourself. So Isha, you go first and then we'll have John introduce himself.
Great. Hi, my name is Isha Mehta. I am an internal medicine physician. I'm working as a hospitalist. I'm a first-year clinical informatics fellow at UNC Health. So I'm in Chapel Hill, North Carolina. So I got into informatics training while doing a lot of QI. My first years in attending over at Temple, I was doing a lot of QI projects. And I realized the next step is really to implement tech in order to affect change. My first project was telemetry, and I thought it was just going to be an education overhaul, but it was an actual EMR change of how the telemetry orders were set up. So I kept doing projects, and then I realized, hey, every QI project is turned into an informatics project, and I need to get some training in this field. So here I am today.
Wow. So you were practicing for how long before you realized that you wanted to do this?
I was in academic hospitals for 3 years, and I decided, let's get some more training. Let's go back into fellowship and get into tech and see where this goes.
Wow, that's amazing. All this education. All right, John, who are you and what do you do?
My name is John Kim. I am also a first-year clinical informatics fellow alongside Isha at the University of North Carolina. And I am an emergency medicine physician by training. I completed my residency training in Detroit at Sinai Grace Hospital just last year, and I went actually just straight into this fellowship program. But prior to starting med school, for 2 years, I was a project manager at Epic, working for the cardiology and radiology application and modules there. So that's kind of what got me first exposed to the field of informatics and kind of to see the potential that it would have down the line. And so, yeah.
So John, how was it working for Epic and teaching doctors how to use the EHR?
Oh, it was so much fun. As you can imagine, talking with cardiologists about big system changes and how they're going to have to follow this 22-year-old's instructions of, changing their whole workflow and practices. You can imagine how fun that is. But with all that, came good experiences. And overall, I think what you kind of had to just realign to was just that this is, the future. This is where everything is moving towards, and we're eventually just going to have to adapt and kind of rip off the Band-Aid mentality.
Well, I think it's kind of amazing that, you went from one side and then to the dark side, became a doctor. And now you can see it from both sides, right? You can see how. Did you guys hear, I just had this come into my brain, that Cerner was just bought out by Oracle?
Yes.
I did just hear about this, yeah.
So wouldn't it be great if they hired you guys to help them make Cerner the best product ever?
Yes,
Because
I think
that's what they need.
I think everybody should hire us no matter what. But yeah, it's definitely a good space to be in right now.
Yeah, I totally agree. Okay, Isha, so let's explain this fellowship. Brag about yourself. How does this fellowship work? Go ahead.
Okay, so clinical informatics, it's a 2-year fellowship training program. It's under the ABPM, so the American Board of Preventative Medicine. So it is a board credentialed and certified field. We learn a lot of different disciplines of informatics. So we learn a lot about the theory of clinical decision support, programming, a lot of tech tools. And then we also do a lot of projects in different arenas. So we will learn about population health, we'll learn about cybersecurity, we'll learn about consumer health informatics, and some of the stuff we're going to talk about today, like telehealth and remote monitoring. So you really learn a lot. Informatics is a very broad field, so it's kind of hard to just kind of define in one nutshell.
John, explain how, because I was confused, the UNC fellowship ties in with the masters at Duke.
Yeah, and so one of the great benefits of going to UNC or Duke for a clinical informatics fellowship is that we have an option to add on a Master of Management in Clinical Informatics at Duke University. It is optional for us, but me and Isha both are actually the first UNC Clinical Informatics Fellows to go through the program, and it's been immensely beneficial just because we're learning in the typical academic setting where we're studying a lot of these concepts that are relevant to what we're discussing today. But also we take that information and then we're able to apply it experientially through experience at University of North Carolina, just because there's such a huge health system that they have so many ongoing projects and that we can do real life applications of those concepts that we're learning. So it's a very good balance. I think it's very good to be have that dual option.
Yeah, I think it's exciting to be on this leading edge of the wave. Telemedicine, as I always say, telemedicine is medicine, and physicians have to understand it in that way. So let's now go to the topic that we're going to hone in on today, which is hospital at home. Isha, explain what that concept is and what you guys are doing. I know it's a small piece of your program, but it's one of the things that I'm excited about. So how does that work?
Yeah, so as fellows, we were able to get involved with with UNC's implementation of hospital at home, which is called advanced care at home. So essentially, our patients who would be traditionally admitted to a brick and mortar hospital are allowed to get their inpatient hospital care at home. So there's a lot of nuance to this. We need to make sure that we're getting the right patients, so that we have a medical screen and then a social screen to make sure that they do have support to receive that 24/7 care at home.
Okay, John, let's take it to the next step. So how do you get this concept off the ground, bringing that team, that village together? Give us some more details.
Yeah, and it really does take a village. One of maybe the challenges of this program it is that it does require a very robust ISD program or the tech side, but also requires a lot of support from the different clinicians that are involved as well. It's a complete overhaul in the workflow as well. And so creating foundation, especially from leadership, from an operational leadership standpoint, you really need buy-in from the top down to say that this is important for our health system, that this is the direction that we're planning to go, and it's aligning with our overall health system's objectives. And once you have that initiative, then you have that activation energy to overcome the large amount of changes that you're really going to need. And also what's really important is that you kind of get early involvement of clinicians and end users, so physicians and APPs as well. They should have a heavy hand in the design and design of the program, so that when it's implemented, it makes sense in terms of their own clinical workflows, and that it implements seamlessly.
Isha, you are a hospitalist, so you're actively involved in these types of patients. Give us the type of patient and their diagnosis that would be good candidates for hospital at home, and then explain how a physician like yourself would be involved in making this happen.
Yeah. So the medical screen is really key with finding the right patient for advanced care at home. So we want to find patients that have diagnoses that we know that we can treat just as well in the brick and mortar setting. So that examples are congestive heart failure, COPD, pneumonia, COVID, cellulitis are all excellent diagnoses that we can treat in the home setting. Like I mentioned, it's really important that that patient also has that home social support and their family can provide care. So after the medical screen and the social screen are done, then we do our intake where they're set up with the technology features at home. The program operates out of a mission control center, so like similar to NASA, where that is where our care team is. So the clinician, the hospitalist is there along with the nurses and the case managers, and that's where a lot of the care coordination happens. So as a hospitalist, you'd be seeing the patient every day virtually, and then the members who are going into the home are your EMS and nursing support. And so they're the ones who are administering medicine, also drawing blood work, And we do have mid-level nurse practitioner going to the home on day 1 and 3 of the model.
This is not easy, right? This is not easy. This is a major, major undertaking. And so, John, it's, explain, it's not really necessarily about the devices, although that's important, right? That they be easy and reliable to use. But let's talk about the buy-in part of it, because that's where I have found in the last, pre-pandemic, it was impossible to get physicians on board. Then the pandemic, then they're forced to come on board. And now we're sort of at this, what we call this trough of disillusionment, right? Where people like, okay, we want everyone to come back to the hospital. We want everyone to come back to the ER and our offices back to the same old, same old. And now this program is flipping what we have learned my whole career on its head. How do you talk to the physicians and the nurses and explain to them and get them to buy in? What do you say?
Yeah, I mean, it's tough. I mean, anytime you're implementing any kind of change, especially in a healthcare setting, it's always bound to be met with resistance. People like doing the things that they used to do and like knowing the things that they know already. But I think one of the biggest things that I mentioned before is just that buy-in from operational and also clinical leadership as well. So establishing that this is a priority and that this is important for our health system, and kind of framing it along the lines of, especially with the onboarding issues that I think nationwide we've been having, amplified by the COVID pandemic. You kind of have to realign it in terms of this is a solution to a lot of the problems that we're having. This is a big change. Yes, it is. But at the same time, it's worth it. And again, I think a lot of it does come down to how early do we get clinicians involved in the design of the program. And so if you have physicians and APPs who are intimately tied with the program, even before its implementation, really going towards when we're actually building out this program, you start to develop physician champions and also nursing champions in that specific sector who can go out and disseminate that information, saying that this is actually a good thing to invest in. This is a good program, and so having that heavy-handed involvement early on in the process, I think, is key.
One of the areas that I'm passionate about is teaching medical students and residents, because it is somewhat difficult to teach an old dog a new trick. But if you can catch them as they're coming into the system, especially they're in the middle of this pandemic, many of the medical students still don't know what telehealth is and how it works. They don't know what remote physiological monitoring is and how this works. So teaching them when they're learning, I think, is another key. Same thing with, teaching them Epic or the EHR when they're just learning. It's just going to be a part of what they know how to do. I think that's another way to get buy-in, right?
Mm-hmm.
Yeah.
I would also just say the model is very consumer facing. If we think about patients, they do not like being in the hospital. It's a very uncomfortable setting. And a lot of our patients just really want to be at home, be surrounded by their family, and get the care kind of on their schedule too. So we are always trying to schedule when their visits are going to be, when we make our phone calls, when we have our daily virtual interaction. So it is very consumer facing. And I think that's represented. The patients have very high satisfaction scores. I think when clinicians start to see that and how comfortable and happy the patients are, they're more interested in the program.
I've never had trouble with patients, Isha.
Mm-hmm.
When I, even pre-pandemic, the patients were always an easy buy-in, right? They totally get it. One of the analogies that I make often is the retail industry or the banking industry, and how consumer facing that is. And so I'm sure you guys are all learning that in your fellowship, that again, it's flipping everything. We're bringing healthcare to the patient, to the consumer. And a lot of physicians are resistant to that. And also, so let's go to the next subject, which is reimbursement. So as long as our healthcare system is organized the way that it is, as dysfunctional and awful and inefficient and expensive and all those adjectives, this is the healthcare system that we have to work with. So right now, Isha, what are the rules of the government, CMS, Medicare, Medicaid, in regards to reimbursement for hospital at home?
Yeah, so fortunately, that's covered under the CMS waiver. So advanced care at home gets reimbursed at the full inpatient diagnosis-related group price. So for Medicare and Medicaid, we are getting reimbursed at the level of the inpatient DRG.
Okay. I think a lot of institutions are very hesitant to, especially small places, for instance, where I live in Wyoming, you've got these rural hospitals, and hospital at home would be such a great asset for patients that live, to see me, that would have to go over big passes and through canyons and things like that.
Mm-hmm.
But smaller hospitals that don't have the volume of patients to scale these things up and are not getting reimbursed well are very hesitant to jump in. Whereas UNC and bigger places that have that ability, hopefully will lead the way to show that this, that this type of concept can work, right? So is there anything else that you guys want to talk about with hospital at home, and like challenges that you've seen? John, what are the challenges so far with hospital at home? What are the glitches that have happened? Technology, devices, family, things like that.
Yeah, not too much. Fortunately, it's been a relatively seamless implementation, given that it's such like a complex, product that we are offering. I think there's a lot of challenges that kind of lie external to our own, just our own local system. Specifically, like we mentioned before, the policies and regulations surrounding it. It's a relatively new program, and so what exactly are the regulatory and compliance pieces that need to be set nationally in order to deliver this and scale it up in a way that makes sense. I think, like you said, reimbursement is a huge part of it. What is the reimbursement structure going to look like 5-10 years down into the line? Are we going to be able to kind of keep up with the structure and the architecture of the actual reimbursement itself? And I think a lot of it right now, CMS is providing that reimbursement, but a lot of these other private payers are not as on board. And so they're not, our patient selection are really limited to those who get insurance through CMS. And so all these other private payers who haven't really onboarded for the program and are not providing that reimbursement structure, even though patient might be a great fit, they're kind of being left out of the equation right now.
Okay. All right. We're not going to have time to go into the details of, the devices and things that you guys use at home. I would love to continue to talk about that at the next. We're going to do this again. So for the audience, we're going to have part 2, maybe in the spring. We can talk about the details of how the devices work at home as the project gets off the ground. And then Isha, give us a little teaser tell us what you're interested in and what we can talk about the next time.
Yeah, sure. I think John and I are both really interested in population health. So one of the really cool projects that we've been able to take on at UNC is hypertension overhaul in our outpatient management. So we've been really trying to incorporate more patient-reported blood pressure readings and trying to say, hey, maybe these are more accurate than our in-office readings where we know patients have white coat hypertension, mass hypertension. So we've been working on different workflows to implement that across the UNC health system.
And John, what's exciting for you in your fellowship? What are you trying to focus on?
Oh man, advanced care at home. It's a no-brainer. I mean, it's such a rare opportunity that we can be involved in such a large-scale implementation of such a new concept, especially at a great place like UNC. And so, just being able to be involved in this process, being involved in like the data analytics side as well, creating business intelligence reports, because all this is fresh and new, and so they need extra hands. And so this is a perfect opportunity for us to kind of get involved in this space.
All right. Well, let's leave it there at the cliffhanger. We'll re-engage in the spring. Hopefully things will be a little bit better in the country. I don't know.
Crossing our fingers.
So you guys hang on one second, but I'm going to end the broadcast. Okay. All right. Thanks, guys. See you soon.